permission to use. Here's Epsy. She's also a family friend, so I have permission to use her photo. So she had a, she actually was a Wilms tumor, or no, a different type of tumor. Yeah, she had, she started with chemo, then she had, it was still a nephroblastoma of types, but she had to remove her kidney, and then she had radiation, and then she had remission, and she did get to do Disney World, so she had her plan, and it was really cool. Okay, so let's talk about chemotherapy treatments. So the slides I'm skipping ahead over, testicular cancer, just remember it can start as early as 15, so start adolescent boys knowing how to do testicular self-exams. We do a lot of plugs for breast exams, but less plugs so for testicular self-exams, and they're important. And then leukemias and lymphomas are blood cancers, and they cause the white cell counts to deteriorate. And so we're going to get to like really what's important for the nurse is how you manage the side effects of stuff. So I'm going to go through the treatments and what kind of side effects the nurse has to manage. Jessica, your lap buddy is awesome. She's really cute. So surgery will be to remove the tumor. The risk of surgery depends on how large the tumor is, how many vessels it has, whether it's invaded surrounding structure. One of the interesting things about that is there's this phenomenon that sometimes when you remove the large tumor, you have like no mets, and then you remove the large tumor, and then like the next scan shows mets everywhere. And we didn't understand why that was so until about, I don't know, maybe it's been 10 years now, but they recognized that what happens is that the large tumor gets selfish. It produces a chemical for neoangiogenesis, for forming new blood vessels, and but it inhibits other little met spots from forming their own blood vessels. It's selfish. It wants to take all the blood and nutrients for itself, and so then you remove it, and the other tumors can start to grow. And so they thought, well, what if we had a drug that would stop the formation of new blood vessels? Well, back in the 60s, we had a drug to stop nausea during pregnancy, and it turned out that we had children born without their limbs fully developed because that blood stops the development of new blood vessels. And that's called thalidomide. And so thalidomide is now sometimes used after surgery in certain types of tumors that have been known to do that, like seeding, so that it prevents like neoangiogenesis of prevents the formation of new blood vessels, and then that keeps the mets from forming. Anyway, surgical care, keep in mind that a lot of cancer surgeries are disfiguring. They can be quite big. They can cause amputations of limbs, and phantom pain is real. So the nerve is cut. Yes, the foot isn't there, but the nerve that fed the foot is still there, and that nerve is saying that there's a problem. And so it's phantom pain is a type of neuropathic pain. It's a nerve pain. So the nurse will need to help with patients cope with altered body image, and as well as to prevent, post-operative complications. Radiation, so common side effects of radiation chemotherapy include fatigue, GI disturbances, bone marrow suppression, integumentary results like radiation burns, or even some chemos cause rashes and irritation with the skin. There's also some adverse or toxic effects to the genitourinary system. So some of them can really cause problems with the, like hemorrhagic cystitis, for example. The nervous system, some cause really bad neuropathies, pulmonary effects. Some of them cause pulmonary fibrosis, and some of them weaken the heart muscle. So we're going to go through which ones do which. Now, these are things that are kind of common to most all of them. So hair loss, GI lesions to the mouth, from the mouth to the anus, there can be GI, lesions, bone marrow suppression, and skin breakdown. What's a common denominator with all of those factors?
The rapid cell growth?
Rapid cell growth, exactly. So those are the places where the cells are growing quickly, and chemotherapy is trying to target cancer cells, which grow quickly. So we skipped over the slides. They're there for you, characteristics of cancer cells. And one of the characteristics is they don't adhere to the instructions to stop growing. They keep growing and they invade. And so a lot of chemotherapies take advantage of that fact and they attack them based on that. There are some theories about cancer-related fatigue. And one of the prevailing theories is that these cells need to repair themselves, and that takes a lot of biological energy. It takes a lot of nutrients, a lot of biological energy to repair themselves, and hence there's fatigue, because the body is really at a cellular level very engaged at healing and recovery. And so that takes away energy for other things. The other theory is it has to do with the anemia that they develop. So this is Chemo Man. I like Chemo Man. He doesn't include all the chemotherapies, but he does help you kind of know which chemos do which. So on the brain, there's the end. Just think of like the wrinkled forehead. I've got a wrinkled forehead there. Nitrosoureas, they can cross that down there where it says XBBB. That means that they cross the blood-brain barrier. So they can be used for brain tumors or because they will get into the brain tissue. So nitrosourea, low mustine, carmustine, they're neurotoxic and they can cross the blood-brain barrier. So they're kind of dangerous that way. They're not used as much as on account of that. Cisplatinum and carboplatinum. So notice that the ears are C's and where the kidneys would be are C's. So your cisplatinum and your carboplatinums, they're nephro and ototoxic. So you've probably noticed that, like, Lasix is nephro and ototoxic. And I find that this interesting. We have this like toxicity for both kidneys and ears. They tend to be developed at the same time embryonically. Children born with like ear skin tags at the ear or little like sinuses at the ear, they want to test their kidney function. So those are kind of interesting drugs that affect both of them. Doxorubicin, so notice that where the heart should be, there's a D. Doxorubicin is cardiotoxic. And so you can have a life in it. Adriamycin's the other name, another one that's another name for it, but you can have a lifetime limit to it. So I think it's like 400 milligrams per meter square or something. So once you reach your lifetime limit, you can't have any more. And before giving doxorubicin, the nurse wants to make sure that the echocardiogram is done. So you have your baseline echocardiogram. And I do mean the nurse, because I can't tell you how many times I would look for the echocardiogram before giving the doxorubicin and it wasn't done yet, because that's where tumor registrars come in place. I'm not tumor registrars, that's where nurse navigators come in place, because like a lot of times the doctor orders all these tests, the patient doesn't know what's important, what's not. They might forget their echocardiogram in the midst of them, or the people from Echo didn't call to make the appointment, or they got the appointment but it's a month from now, but their chemo is 4 days from now. So that's where having a nurse navigator, making sure that they get these things in the right sequence is important, because you want a baseline echocardiogram to see what the damage is. One client I knew that had Hodgkin's lymphoma, got some doxorubicin. She had no problems. I mean, her echo came back fine post surgery, but when she got pregnant, and that was another funny story because she got pregnant when she shouldn't have been, technically. She could have been sterile from the chemo that she got, but she got pregnant. And we discovered that at her 6-month CT scan to see if her lymphoma had returned. Baby turned out well. But anyway, she developed heart failure during her pregnancy. And it turned out that although the doxorubicin didn't cause enough damage to show up on an unstressed heart, when the heart became stressed from all the extra fluid of pregnancy, she went into heart failure, and it was related to doxorubicin. So she had to be very closely monitored at the end of her pregnancy. Then the MF are on the long bones, and that's because methotrexate and 5-FU cause really, all of these will cause some myelosuppression. Myelosuppression is like the bone marrow suppression, but the methotrexate and 5-FU are really, and that's 5-fluorouracil, they really cause severe myelosuppression. They can also cause some more skin and mouth sores and things like that. They're really kind of caustic agents. The P is for cyclophosphamide, with a P at the where we urinate. But we'll just say P because it goes with cyclophosphamide. And it causes hemorrhagic cystitis, lots and lots of bleeding from the bladder. So this is one that is sometimes you can take orally. So if you're giving it to a client to take it home, you need to tell them that they need to take their last dose no later than 3 hours before bedtime, because you want them to be able to flush it through their system before they go to bed. So when people are on cyclophosphamide, you want them to be urinating every 2 hours. You want to make sure that they've flushed the chemo through their system before they go to bed. They need enough fluids, like they need 3 liters a day as the floor, as the minimum, because you want them urinating pretty robustly every couple of hours, because cyclophosphamide gets eliminated pretty much unchanged. So it doesn't really go through like a metabolism by the liver. It just gets eliminated pretty much unchanged. So then you have the bladder sitting there holding chemotherapy in it, and that damages the cells of the bladder, and they end up having hemorrhagic cystitis. So watching for blood in the urine is really important. And the way to prevent that is to just dilute it, right? Just dilute it, which means they need to be drinking a lot of fluid, and you don't want them taking it at bedtime and it's sitting in their bladder overnight while they sleep, because then they're going to wake up and pee blood. So you want them to flush it out of their system before they go to bed. The vinca alkaloids, notice the fingers and the toes are V's. That's for the vinca alkaloids, the vincristine, vinblastine. They cause peripheral neuropathies. So that's why the fingers and toes are V's. And so if you're going to give vincristine or vinblastine, if you're going to give any of those, you want to assess how much neuropathy they have. Do they have numbness and tingling at the tips? Generally speaking, if the numbness and tingling were at the tips, we let that go. But if the numbness and tingling got to like the first joint, then we would pretty much stop using these drugs, because nerves only repair about a 0.5 centimeter, every 6 months. So if you go past that first joint, they're going to start having real problems with dexterity, picking things up and living their life. Another thing to keep in mind about the nephropathies is the nephropathies are also affecting the nerves that innervate the gut. And so these drugs that cause topotecan is another one. It's also a plant alkaloid. It's not a vinca plant, but it's a different plant. It's a newer one, but it causes neuropathies, but the neuropathies also affect the gut. So a lot of chemos tend to cause more diarrhea, but the vinco alkaloids tend to cause more constipation because they don't get a coordinated peristalsis because of the neuropathy in the gut. Okay. And then the lungs are Bs, and that's because busulfan and bleomycin can cause pulmonary fibrosis. They also tend to cause a really bad anaphylactic reaction. So with bleomycin in particular, you give a test dose. So we used to give a small subcutaneous dose of bleo before we gave the dose, and I'm trying to remember, yeah, it was subcutaneous, before we gave the full dose, and we would wait and see if they had any kind of reaction, and then if they did, then obviously they couldn't have bleo, and if they didn't, then we could give them the bleomycin. But we would actually do the test dose before, like, not just the first, but also the second round of chemotherapy, because remember, sometimes the body gets introduced to the foreign antigen, and then the second time it sees it is when it reacts to it. So we would do that test dose again. And but for those clients on bleo and busulfan, pulmonary fibrosis is when they have decreased elasticity. So it's a restrictive airway disease. You know how we focus on obstructive airway diseases where the lungs get overstretched and they get barrel chested? These people have a restrictive airway disease where they can't get the lungs fully expanded. The lungs give them resistance to fully expand. So they have trouble getting air in versus trouble getting air out, like obstructive people. So pulmonary fibrosis, you would hear rubs, you would hear like just really coarse breath sounds. So you want to listen to the lung sounds quite frequently. So when it comes to test questions for chemotherapy, although there's a lot more chemotherapies than just these would be the agents, and knowing these particular toxicities are going to be important. As far as the nurse, when you're administering chemotherapy, you need to protect yourself. So this person is probably the pharmacist preparing the stuff underneath a hood. So like a lot of times, even when we would spike and prime our bottles, we would do that under a hood. Or I would prime normal saline all the way to the tip, and then I would back prime the secondary tubing. I would let the secondary tubing fill with normal saline and then spike the chemo. You never want the chemotherapy to drip out. So if you're not going to back prime, then you want to be doing that under a hood so that any chemotherapy that gets aerosolized, gets sucked up and filtered. You want to teach your clients, and you want to do this in the hospital, flush liquid waste twice. So cyclophosphamide isn't the only chemo that gets excreted in a way that's still active, still an active component. So you don't want to be exposed to their liquid waste. I mean, I know we don't want to anyway, but you got to think about like aerosolization. You know, when you flush, things get aerosolized. So it's a good idea when you have lids to close the lid of the commode when you flush, and to flush twice. If you're administering a chemotherapy, like cyclophosphamide, I said, can be a pill that's oral. Topotecan can, not that one, thalidomide's a pill. You want to make sure you don't handle those pills. It can possibly get absorbed through your skin. Prepare them under hood. And generally, if you're pregnant, you probably want to shy away from like being the chemotherapy nurse. I have worked in infusion centers with a woman who was pregnant. She just always wore her chemoprotective gear, always back primed, just was very careful not to aerosolize. And her babies turned out fine. So I think, you know, a lot of it is just using the precautions. Chemotherapy gloves are thicker than your regular nitrile gloves. So they're a special glove. The gowns are actually thicker than the yellow isolation gowns. You want to wear goggles to protect your eyes. You want to wear something to protect inhaling it if it's going to be, if you're going to be doing that. So. All right, so here is external beam radiation. So radiation therapy via external beam. I wanted to show you this picture. This is like those head and neck cancers, those kids that had brain tumors and were radiating the brain. This is what you kind of use. It comes out flat and you just kind of get it warm in warm water and you stretch it over the person and it molds to their face and, you know, literally molds to their face. And then this way we don't have to tattoo the face. We would put the marks on this mesh thing and that's what keeps them in position. So that might explain to you why we have to sedate children who are going through radiation therapy, because that looks pretty claustrophobic to me as an adult. I can't imagine a child being okay with that. Actually, I was surprised. We had children as young as 5. I had a real mature 5-year-old that actually did it without sedation. But we played a game. So we would play like, you know, the freeze frame kind of game, freeze, and then we'd go give him his radiation feedback as quickly as possible. So this is what is known as a linear accelerator. This whole camera looking thing can rotate 360 degrees. The table can rotate side to side. And so one of the ways we minimize damage is radiate the tumor from multiple angles. Because it usually takes about 8,000 centigrade or more to kill a tumor. But after 2,000, you are damaging the skin. After 3,000, you'll have permanent hair loss. So what they do is they try to like, okay, let's give 1,000 from this angle, 1,000 from this angle, 1,000 from this angle, 1,000 from this angle, right? You approach it, you get 8,000 at the center tumor, but you're approaching it from 8 different angles so that hopefully you don't get any permanent hair loss. But usually there's that patch that there's a little overlap and you might hit that thing. With external beam radiation, the patient is never radioactive. Okay, so the radiation travels in a straight line, linear accelerate. It accelerates, travels in a straight line. It can go through you know, you have to have like walls that have 6 inches of lead or 2 feet of concrete, which is why a lot of times these radiation centers are built in basements, because, you know, you need the concrete or the earth or whatever, because it'll just keep traveling. The markings, if you're dealing with someone who has radiation therapy, they may have markings on the skin. The markings define the radiation field, so we don't erase them. All right. With external radiation, protecting yourself involves paying attention to the signs, knowing where the emergency stop buttons are so that if you end up in the room, you can stop the radiation. Announcing yourself, that's the main thing I would do when I worked with the radiation therapist, is I would just tell them, I'm going in the room now. Like, I'd make sure they knew I was going into the room. You know, when they say everyone out, leave the room. And wear your radiation detection badge. In all my years of external radiation, and I did like 4 years of external radiation nursing, I never had a positive badge, just so you know. Now, internal radiation is different. Internal radiation, there's 2 kinds. There's like one that they swallow, and also one that you can put in them either temporarily, like the vaginal cylinder, or permanently, like prostate seed implant, or like I said, swallowing, like the radiation swallow. And if they have a radiation swallow, their secretions are radioactive. And your trick when you're dealing with internal radiation is limit the time you spend with them, no more than 30 minutes a day. So that's in your whole entire shift, no more than 30 minutes with them. So a lot of times in order to be eligible for internal radiation, we have to make sure that the client is basically able to care for themselves. If they would require a lot of assistance, then they would not be eligible for internal radiation. They tend to have nausea. Most of the time, you can give your antiemetic, and it's not that I wouldn't, I could wear the apron and go push an antiemetic and be fine. You can have like that 30 minutes. The only time I ever had one of those badges show up, I took care of someone and she got really sick, really nauseated and vomiting, and she vomited when I was in the room, and that's the one that the badge came on. And I got 1 centigrade, which is about the equivalent of what we'd get if we flew from San Jose to LA. So you get more radiation when you fly. So it was kind of like the equivalent of a chest x-ray, or from flying San Jose to LA. It wasn't like enough to be lethal, but I wasn't allowed to care for the internal radiation clients for the rest of the month because you don't want it to build up. The main thing is distance, increasing the distance between you and the patient, or placing a lead shield between, or lead apron between you and the patient. So a lot of times we'd have one of these shields at the door so that you could step in and say, how are you? Do you need anything? And, you could step in and the shield came to your chin and covered your thyroid, and you could do that. The internal, do I have pictures of the seed implants? Internal, they can be like seed implants, like little seeds that they put in a prostate, for example. Those stay in the patient and they gradually lose their potency over time. And so, should I go in? No, this is pediatric. I don't have to go too much into the prostate. But just the same,
No.
yeah, time and distance is the main thing, right? Limit your time, increase your distance. So signs and symptoms for leukemia are all those same signs and symptoms of anemia plus frequent infections. Okay, so they have all these white blood cells, but their white cells do not, their white blood cells are immature, so they can't fight infections very well. So it's kind of like, I think of like World War II, when towards the end of World War II, when Germany was losing, they started like recruiting 12 and 13 and 14-year-olds into the army. Well, if you've got an army that's that immature, they're not effective, right? So that's the thing with leukemics, why they have so many white cells. They might have, they might have 40,000, they might have 80,000 white cells, but they're immature white cells, so they're not effective to fight infection. But because their body's making so many white cells, they don't make enough red cells. So that pallor, that fatigue, that shortness of breath, all of those symptoms that go with anemia often show up with leukemia. And I said here, the title is a hyperlink, so that helps you answer all of those questions right there. So feel free to do that. So the nurse is usually involved with helping with the side effects. So one of the main side effects of chemo and radiation therapy is bone marrow suppression. Bone marrow suppression means you don't get enough white cells, you don't get enough red cells, you don't get enough platelets. So leukopenia is the decrease in the number of white blood cells. Neutropenia, you'll hear used interchangeably, but they're not exactly the same. Leukopenia is all white cells. Neutropenia is a decrease in the neutrophils. Obviously, if your total's decreased, your neutrophil is going to be decreased, but they will sometimes talk about an absolute neutrophil count, which is when you take the percentage of neutrophils. So let's say the neutrophils are 70%, but your total is 2,000, then it would be 1,400. It'd be 70% of, so 70% multiplied by 2,000 would be 1,400, would be the absolute neutrophil count. When the absolute neutrophil count gets less than 1,000, the person, when it's less than 3,000, the person's at risk for infection, but when it's less than 1,000, it's kind of like they have very little, if no, defense against infection. Anemia, those signs are fatigue, dyspnea, shortness of breath. You can treat the symptoms, like you can give them some oxygen, you can give them some rest, and you can transfuse red blood cells. So you can't, so you can replace red blood cells with transfused red blood cells. Thrombocytopenia is decreased platelets, not plates, but platelets. I think I was abbreviating. The risk of bleeding occurs because platelets are responsible for clotting, and so then the risk of bleeding occurs. The nadir, which is the low point. So the nadir is the lowest point. Then the lowest point for the red, white, and thrombocytes is not the day of chemo. It's like 7 to 10 days after chemo. And because what happens is chemo is affecting the rapidly dividing cells. So it's not affecting the red blood cells and white blood cells and platelets that are in circulation. It's affecting the ones that are being formed in your bone marrow. Now, every day, some of our red cells, white cells, platelets have done their job and they're dying off. And every day, new ones are being put out there by the bone marrow. But if you do a chemo or radiation and you damage those dividing cells in the bone marrow, the ones that normally would die off still die off, but there's not new ones to replace them because now the bone marrow is behind because it was disrupted. So that's why it's 7 to 10 days later that you notice the suppression. So neutropenia leads to infection. If you have no neutrophils, you don't have those initial, remember we said neutrophils show up when there's new infections, you don't have those initial cells that fight infection. Now, because you don't have those cells, a lot of the symptoms we see when there's infection, the pus, the redness, the pain, all of that kind of stuff, a lot of that's a result of the inflammatory response. Remember learning about the inflammatory response as a concept? Well, if you don't have neutrophils, you don't have an inflammatory response. So a lot of times people with low neutrophils count will have very little signs and symptoms of infection, and the only symptom you may see is only sign you may see is an increased temperature. So I always tell students, it's like in a cancer patient, fever is to a cancer patient like chest pain is to a cardiac patient. It's a pretty serious sign, and you don't try to get rid of the fever, you try to find out where the infection's coming from, because until you find out where the infection's coming from, the fever is their only defense. They don't have any other defense. They don't have any white cells to attack the bacteria. So if you get rid of, or the virus, so if you get rid of the fever, you're getting rid of the only defense. I mean, and that's been illustrated out with the COVID virus. They're saying like, people that take ibuprofen have a longer case of the virus. Well, why? Because they're getting febrile, they're running a high fever. That's their body's defense to kill this virus. But if you take ibuprofen, you're shutting down the defense. So then that's actually allowing the virus to replicate more. And that's what we're doing when we shut down the defense when somebody has no neutrophils. So they have an increased risk for infection and an increased risk of severe infections. And here's kind of the risk. Less than 500. At less than 500, they actually will get infected from their own microbes. You know, the microbes that are normally, you know, so a lot of times they did this study when we first did bone marrow transplant, we would have to totally gear up to go into the room, and they kind of put them in a bubble, and then they kind of got lax on that, and I think they've kind of pendulum swing to too lax myself, but part of the rationale for that is when they did the study, 80% of the infections these people were getting were endogenous bacteria from their own bodies, not something that was exogenous, not something that was brought in from somebody else, but something that they had in their own selves that became infectious because they had no white cells. So neutropenic precaution means protective isolation. It means you put the person in a positive pressure room. So you know how with TB, you want a negative pressure room so that when you open the door, the air from the hallway rushes in and none of the TB gets out to the hallway. Well, in these patients, you want them in a positive pressure room. You want, when you open the door to go into the room, they want the air to rush out of the room so that none of the germs from the hallway go into the patient. You also want to, you're going to do meticulous hand washing. You're going to wear a mask when you're with these clients, especially like if you're going to be up close starting an IV or doing a dressing change. You want no raw fruits or vegetables. They can have canned fruits, canned vegetables, but nothing raw. You can't rely on the normal signs and symptoms of infection. So you want to pay attention to fever and pain. So like a normal central line that got infected would be red and hot and swollen and puffy and painful. The cancer patient could have a raging infection in the central line, and all that you're going to notice is they're like, that's really tender right there. So like I would often palpate like lightly with my fingers over the occlusive dressing to see if I had elicit any tenderness. And they can look perfectly fine, not see any redness, but be infected because, right, that redness is the inflammatory response that comes from the neutrophils responding, which we don't have. You tell the clients to avoid crowds and avoid fast foods and, you know, those kinds of things to keep themselves safe. For anemia, we treat symptoms, not the number. So we might need to do transfusions and monitor the transfusions. But keep in mind that the more transfusions people have, the more of those rare antibodies. So we all know about A, B, and O typing, but there's, you know, alpha and delta and epsilon, and there's, you know, delta 1 through 66 and epsilon, I don't know how many, they have like all, you know, they even have kappa. They have all these other markers on the red cells. Now they're in such minute quantities that most of the time it's not a problem. But when somebody's had multiple transfusions, like 2 to 3 transfusions a day for 3 weeks during their induction chemotherapy, when they go back for their consolidation chemotherapy, because induction is to induce the cure and the consolidation is to kind of maintain that and to, you know, really make it solid, they might start having more transfusion reactions. So be very careful about transfusion reactions. Do not rely on the pulse ox. Pulse oximetry is not accurate when somebody's anemic. Pulse oximetry tells you what percentage of cells is carrying oxygen. So if I'm supposed to have, you know, 16,000 red cells carrying per deciliter carrying oxygen, and they're 90% saturated, or, you know, 98% saturated, of course I feel fine. But the person can have 98% saturation, but only have 8,000 cells per deciliter. So they have half as many red cells carrying oxygen. And so your pulse ox can say 98%, but they can still be dyspneic. So trust your client. Of course, they're pale. Be alert for chest pain. Monitor for bleeding, because sometimes the anemia can be from GI bleeds, like the methotrexate we said can cause a lot of sores, mouth to anus, those kinds of things. You want to increase the oxygen supply and decrease the oxygen demand. So to decrease the oxygen demand, you cluster your care, you balance activity and rest, and you encourage small meals versus large meals, like small frequent meals, because digestion takes a lot of oxygenation. You guys doing okay? Got a lot to get through, so if I'm going too fast, let me know. Okay, thrombocytopenia. So thrombocytopenia is a low platelet count. Platelets are responsible for bleeding, or for clotting, so without them you get bleeding. So you want to assess areas for signs of bleeding, the gums, the stool, right? You know, black tarry stool or actually frank blood in the stool. The emesis, does the emesis look like coffee grounds, which could be blood? Did they get nosebleeds? Also paying attention to altered level of consciousness, right? They can have a brain bleed, especially when the platelets get less than 20,000. People can actually spontaneously bleed, like they don't have to bump their head to have a brain bleed. Petechiae are those little pinpoint little, like they look like someone took an ink pen and made dots and smeared them a little bit to me. They just look like teeny tiny dots of purple spots. Purpura are like larger bruising looking spots. And those are signs of, so petechiae happen when the capillaries kind of break, they rupture and bleed. That happens all the time with capillaries, but most of the time the platelets patch it up and we never know about it. But you'll often find the petechiae initially at the feet and ankles is where you might see it, right? Because there's more pressure if the person's standing on those little capillaries. Platelet counts less than 140 is considered abnormal. Now, when you're an oncology nurse, you don't really start to sweat it until they get less than 50. Then you're like, okay, then when they get less than 50, I'm telling the patient you need to watch these bleeding precautions. When they're less than 20, now I'm afraid that they're going to bleed if they look at me wrong, or if they sneeze, or if they bump the rail. They can have a slight bump on the side rail and go and have like a massive bruise from a little bump when they're less than 20. But less than 50, like, it's really funny. I have a friend who's a surgical nurse. She saw someone who had platelets of 80 and she's like, oh my goodness. I think it was her sister was going through the chemo. Her platelets are only 80. I'm like, oh no, she's going through chemo. That's just fine. I'm like, we're going to sweat it when she gets less than 50. So it's all perspective, right? So bleeding precautions mean brush with a soft bristle toothbrush. Use caution with activities. Don't have them do contact sports. Be careful with intercourse. So, not too vigorous of intercourse. If it's less than 20, they should avoid it altogether. Pay attention to adolescents. Make sure to talk to them about that, right? Because everyone's telling them have no sex, but they might need to know that you're saying don't have sex because you can, end up with a massive bruise on your penis or in your vagina because you don't have any platelets. Use electric razors, not straight razors. Hold bleeding sites for at least 5 minutes. And by holding the site, it doesn't mean hold and then look, and then hold and then look. Because if I'm looking every 30 seconds, every time I look, I'm letting that clot break open again. It means hold for 5 minutes and then look. If it still bleeds after 5 minutes of holding, then they should go to the emergency room because they probably need a transfusion. No NSAIDs, right? Because NSAIDs and non-steroidal anti-inflammatory drugs like aspirin and ibuprofen, those NSAIDs can cause lack of platelet aggregation. We want what few platelets they have to be sticky. If the few platelets they have are not sticky because we give them an anti-platelet aggregate like an NSAID, then we're going to get no clotting at all. So fatigue is another thing that we try to manage as oncology nurses. Like I said, the causes, theories can be the cellular demands, the cellular demand of the cancer wanting a lot of nutrients, the cellular demand of the body trying to repair itself, the healing, the energy it takes to heal, to repair. The tumor itself may create some of the fatigue. Tumor's selfish, it takes the nutrients first. That's one of the things I try to tell people when they're like, their loved one has advanced cancer and they're passing from advanced cancer and the loved one's concerned that they're not eating. I try to let them know that, at this point, the tumor is taking all the nutrients. So if we feed, if we started tube feeding, it would likely just feed the tumor. It wouldn't help your loved one have more nutrients or feel more comfortable. It would likely just feed the tumor at that end stage of life that happens. Anemia is another reason for the fatigue. and just the emotional fatigue. These people are fighting for their life, right? They've got the unknown. It might be a 80% curable cancer or a 90% curable cancer, but are they going to be in that 90%, or are they going to be in that 10%? There's that emotional fatigue of, of the unknown, and if they're going to make it, or the emotional fatigue with facing that they are going to die from this. So that's a huge fatigue. I had one, I told you my teenagers were often profound when they were passing. I had one teenager say that he had a Make-A-Wish, and what he wanted was a really big birthday bash at the beach, and which got arranged. And he had prepared everybody that after this birthday bash, basically he was only going to take visits from immediate family. And I was in the room as his mom was asking him about that, like, well, because he was developing a list of who could come after the party. Like the party, everybody was coming, and then it was very limited, and Mom was surprised that somebody wasn't allowed. And he goes, Mom, what you don't understand is everybody has to say goodbye to me, and I know that that's really hard on them, and I want them to say goodbye to me at the party when I'm feeling good and we're having fun. He goes, but it's really tiring because I have to say goodbye to everybody. And I thought that was really profound, right? So that's part of the fatigue too. The interventions for fatigue are balancing activity and rest. What I've discovered from my years of experience is patients who had jobs that were unforgiving and they had to work, and they had no downtime, or they had toddlers and they couldn't stop what they were doing, they experienced excessive fatigue. People who were like, oh, my work said I can take off, and they stopped everything. They stopped going to church. They stopped, going, they're just supposed to avoid crowds if their counts are low, but, they just stopped everything, and they were resting all the time. They had more fatigue. The people who manage fatigue the best are the people who have activity periods, because activity makes us rest well at night. So if we do nothing all day and then we don't sleep well because we're restless, that's not good. So balancing activity and rest seems to be the thing. Clustering your nursing care so that you can plan for some active periods and plans for some restful periods of the day. Ambulating does help. There's been studies that show that, ambulating, getting walks outside do help people with their fatigue. You guys have probably noticed this with the COVID isolation. You start getting a little stir crazy, and if you just go take a walk around the block, you might feel better. And so the main thing is tell people to listen to their body, rest when they need rest, and be busy when they need busy. The other things we often deal with as oncology nurses is GI disturbances. The problems can relate from stomatitis, which is ulcerations in the mouth, esophagitis, like inflammation in the esophagus, nausea, vomiting, lack of appetite, diarrhea, and constipation. And so your interventions for stomatitis include using a soft bristled toothbrush and rinsing with normal saline or baking soda rinse. Sometimes they get a xerostomia where their secretions get really thick and dry. And so when that happens, a little bit of peroxide can kind of break that up, and make sure they know to spit that out and not swallow it. Mucositis, the esophagitis, soft foods, warm room temperature foods. Also, for those two up top, there's sometimes the doctors would have a compounded medication. I've seen it called Miracle Mouthwash, magical mouthwash, just the cancer, or just stomatitis mouthwash. And what it usually is a blend of Benadryl, right? Because it's an antihistamine, so it's going to cut the inflammation. Maalox, which is an antacid, so it's going to kind of coat and provide a barrier against the acids. Nystatin, because a lot of times these people are prone to fungal infections because, right, they don't have white blood cells. Nystatin and lidocaine, viscous silocaine, to numb the mouth. And so that it comes to like a pinkish kind of pinkish yellow liquid, because the Benadryl can be pink and the nystatin's yellow. But then the white base of the Maalox, and they're supposed to kind of like gargle it. And if they have the esophagitis, they can go ahead and swallow it slowly to help it coat. I tell them swallow little bits to kind of make it coat, and then or they can spit it if they don't like the taste and they don't have esophagitis, but often they'll have both. For the nausea and vomiting, you want to give antiemetics. The HT3 antagonist inhibitors, so the dancetrons, ondansetron and ganzetron, they all, and like that. Those have been, they target the chemotherapy receptor zone in the stomachs and in the brain. So they target those areas, and they're most effective for cancer-related nausea. The other thing that's most effective for cancer-related nausea is don't let them get nauseated. You give the antiemetic before the first treatment. If they're taking something like carboplatin and cisplatin, which we know will cause severe nausea and vomiting for about 72 hours, don't tell them take it PRN. Tell them PRN as needed means you're going to need this one. This one's emetic profiles for 72 hours. This one has an emetic profile for 24 hours. Look at the drugs. Chemotherapy books will tell you, like, it's a emetic profile, how likely it's to cause nausea. If it's 72 hours, then I tell them, take this around the clock for 72 hours. Because what happens is they'll get what they call anticipatory nausea and vomiting. And before the days of the dancetrons, when we didn't have those drugs, we would get a call, meet so-and-so at the elevator with a bucket. Literally, the oncology floor I worked on was on the 8th floor. Literally, they would go through admissions, they'd call and say, meet him at the elevator with a bucket, we're taking him to the elevator now. And literally, they'd hit the floor and vomit. And that's what anticipatory nausea and vomiting, like they've associated with that being there with being so sick. So if you can prevent vomiting, that's better than trying to treat it. Use bland foods. Favorite foods between meals for the or between chemotherapies for the anorexia, but not when they're nauseated, because then you lose the favorite foods as things to keep them nutrition up. Diarrhea, constipation, then of course you're going to watch that fluid and electrolyte balance. If there's diarrhea, you're going to replace the fluids, you're going to replace the electrolytes. If they're taking like the vinca alkaloids, any of the things that cause peripheral neuropathies will also cause neuropathies in the gut, which is going to cause the peristalsis to be less coordinated, which is going to lead to constipation. So if you see constipation, stool softeners are helpful to prevent that. And sometimes the stimulant laxative. For the skin, alopecia is hair loss. It can be permanent if it's radiation. It would be temporary if it's not radiation. You want them to, you can encourage hats, wigs, scarves. Keep in mind, hair loss includes everywhere, eyebrows to the toes. So sometimes the loss of hair around the genital region can be disconcerting to patients. They don't feel like they look like their usual selves. So those are important things to kind of like forewarn people that happens. One of the tips, evidence-based practice, is to deal with hair loss is encourage the wig shopping before the hair loss. Because if I went wig shopping right now and I have my hair, I could be like, oh, it'd be fun to be a blonde, or, oh, I like this kind of like reddish brown. This is kind of cool, or, and you are having a little bit more fun with it, because when you take it off, your hair is there, and you can compare how you look with the hair versus how, with the wig versus your usual hair. When patients go wig shopping after they've already lost their hair, they tend to not be satisfied with any wig that they find, because nothing looks like them. So going when they still have hair is a good thing, because they tend to then have fun with it, right? You can kind of have fun with, your personality or whatever. oh, maybe it might be fun to try this, but when they've lost their hair, every time they take the wig off, they see their bald head. Every time they put the wig on, it doesn't look like them, and there's just less satisfaction. With radiation, you may get desquamization, erythema to ulceration. So desquamization is the disruption of the skin growth. So it's not a burn like a sunburn that comes from the outside in. What's really happening with radiation burns, they call them burns, what's really happening is that it's disrupting the dividing cells in the dermis, right? The dermis is dividing and to create the epidermis, and the epidermis is always having skin fall off, right? And so the skin falls off, but you have new skin ready to be there. Well, if you're disrupting the cell growth in the dermis and the skin falls off, you don't have new healthy skin available so now you have desquamization, you've lost your skin. So initially you'll see the redness, the erythemic region, but eventually it'll be open and kind of ulcerated looking because the skin falls off and there's new skin underneath that's raw, that's not fully formed. So using loose fitting and soft clothing, things that don't rub or irritate is important. Using approved lotions only, nothing with alcohol in it, nothing with metals in it. Really avoiding fragrances is a good idea. Swing cream is often good. Aloe vera gel that's not alcohol based is really good. Aquaphor, even though it's oil based, you don't want them to have the Aquaphor ointment on during treatment. You don't want to have any oils or metals, like no deodorants, if they're going to get that region of their body radiated. But you want to have, you can put it on after. Keep their skin moist, keep it protected, protect it from the sun. Don't scrub, like just use their hand to put on the soap. Don't use or use a really soft, like bath sponge versus a rough cloth or a very soft cloth. You don't want them rubbing their skin. Some chemotherapies will cause photosensitivity or acne or just plain rashes, like the methotrexates can do that. Encourage clients to stay out of the sun. What's really interesting is I've had clients who've had radiation like years ago, and now they have a relapse, they're getting chemotherapy, and their radiation areas will light up. It's an interesting, like it's called radiation recall. And something about the chemotherapy will cause like redness. And you know it's radiation recall because it's like linear edges, and it's right where they had radiation in the past. They'll get some really severe hyperpigmentation if they're in the sun with some of these chemotherapies. So they need to protect, wear hats, wear long sleeves, that kind of stuff.
Mr. Beamer, you have about 5 minutes left.
Okay. Is there something in particular you want me to keep going? Is there something?
You only have a couple slides left, so.
Okay. Well, good. Then I'll open it up for questions. Genital urinary is nephrotoxic. Yeah, nephrotoxic drugs. Yes, there's nephrotoxic drugs, like we talk about the Cytoxan or cyclophosphamide, right? It's going to cause irritation to the bladder lining, and you really want to hydrate aggressively, probably more than 3 liters of fluid. Also keep in mind that a lot of these drugs cause reproductive dysfunction, sterility, because your gonads can be rapidly dividing cells. But it can also cause mutated cells, so you want to encourage the use of condoms during intercourse. You can also lose if it's like radiation that involves the pelvic region, like for cervical cancer, which is why, it's so great that we now have the HPV vaccines, because it would cause loss of elasticity to the vaginal area, much like aging would cause. And so, and loss of lubrication. So in those cases, talking to the client about if they need a vaginal lubricant or something like that might be helpful. Nervous system, watch if they're getting brain radiation, they're increased risk for increased intracranial pressure, right? So that's the headaches, the nausea. I think that's one of the concepts that it comes out, like, because you have the hydrocephalus in infants and you have intracranial pressure with injuries, and you have, so knowing how to manage that, right? Elevating the head of the bed, managing, keeping the blood pressure low, managing fluid intake, those kinds of things. Giving osmotic diuretics. For peripheral neuropathies, there's not a lot you can do. You just have to pay attention to how much peripheral neuropathy you get, and maybe not continue with treatment if it's getting too bad. Like I said, kind of past that first joint of the finger, they usually stop. The pneumonitis and hypersensitivity reactions with the bleomycins and busulfans and the doxorubicin can cause the thickened pericardium, and that ends up causing the heart to be less elastic, which ends up leading to heart failure. So cancer survivorship. Thankfully, we have more young people surviving cancer than ever before, but they may have delays in meeting their developmental milestones because they spend a lot of time in the hospital. They often will have that emotional maturity beyond their years, because, you know, how many of us have had to face death straight on and, you know, deal with pain and suffering bravely because you're getting IVs on a regular basis. But, you know, they still might, you know, be younger than their years socially. If there is central nervous system radiation or chemo that crosses the blood-brain barrier, they have been shown that they'll have learning disabilities. So you want to alert the parents to, like, get them plugged into services, get them a special IPE plan for them. If the radiation is over growth plates, they may have stunted growth. Like when clients have lymphoma at a young age, they might have smaller than average chests because it just, or they might have a limb if it's a sarcoma, shorter than the other. They may have alterations in fertility that could be lifelong. When we have a leukemic child who's going to go through a bone marrow transplant, the good news is bone marrow transplants, there's, you know, they may have long-term survival. The bad news is the parents are signing this consent form that says that, you know, your child's going to have may have learning disabilities. Your child may have disrupted growth patterns. Your child may be infertile for the rest of their life. Your child's at risk for increased secondary malignancies, so they can survive this and end up getting another cancer when they're in their 30s. They're at risk for early dementia. Now, making it to 60 and getting dementia, you know, 60 is early for dementia, but making it to 60 is better than not making it to 60. But that's really hard. Parents sign these consents that basically your child's going to have trouble for the rest of their life because you're being treated for cancer now. And just recognize that any drug that treats cancer can cause cancer. So all of those drugs that treat cancer disrupt they're all designed to disrupt the mitosis, to disrupt cell division, to disrupt the DNA, particularly your vinca alkaloids and your, what's the other, alkylating agents. They disrupt the DNA, so the person's at increased risk for a secondary malignancy later. And then having those life and death conversations with people is one of the touching moments as an oncology nurse, and also one of the difficult moments. Okay, so that's the end of the PowerPoint. What questions do you guys have? We are at time, but I can hang around for a bit if you have questions.
So I had a quick question. So when we're giving radiation to a specific region of the body, like depth of the tumor, does it differ how long they do it, or like you can give one, like let's say like powers 1 and it will be same effect?
Okay, that's a really great question. So they can use proton beams or electron beams. So electron beams don't go very deep. So we use electron beams for like skin cancers and very shallow tumors. They can go like, I think 1 to 4 millimeters deep. So they're great for those kinds of things. For anything that's inside the body, they do proton beams, and proton beams will basically travel until they're stopped, and they're only stopped by 6 inches of lead or 2 feet of concrete. So they travel through the body. So radiation, you'll have radiation effects at the entrance point and the exit point. So you'll see the radiation skin reaction. I mean, it's losing its effect as it's traveling through the body, but it does travel all the way through.
Okay, got it. Thank you.
You're welcome. And that's why we change the angle so that we do less of a impact on the skin and the surrounding structures, and change the angle so that all angles lead to the tumor, but all entry and exit points are slightly different.
I have a question, please.
Yes.
I had a cousin who was treated for cancer. He was a grown man, and his wife. And I know that after he would have some of his treatments, and then he would end up coming home, they would tell her that she could not be in the room with him, because of the radiation and things like that. So they had to be separated for a while. How do they handle that with children who, when they're kind of going through something like that and their daddy can't be with them at that time?
So that's an internal radiation treatment, and most of the only cancer that might happen in a young person that I've seen that gets, well, you can get a thyroid cancer fairly young, but they're still usually in the early 20s, and the other one would be a cervical cancer. And so generally speaking, I don't think that there's any small children that we use a internal radiation source with. So cervical cancer has the vaginal thing, and it's a really, it's a barbaric looking device that stays in the person for a few days while they're in the hospital. And then the thyroid one is a radiation swallow, but they're usually, like I said, in their 20s. It's not something that we generally see much younger than that. So I have not come across a child who would need like regular care, who needed
some type of something, inside. Yeah, because I wasn't exactly sure, what types of things he was getting, but I just knew that, there would be times when he would come home and she would have to, sleep in a separate room. And I didn't know if they had things like that also happen with children.
Yeah, that was definitely with radiation. And then with the chemo, if you do have a child that's on chemotherapy and they're not potty trained yet, you do want to let the family know that changing that diaper like immediately is going to be very, very important, because that chemotherapy, like I said, a lot of it gets excreted virtually unchanged. And so it's going to be super caustic to the skin. And the mom might need to wear gloves to change the diaper, because you don't want the mom's skin exposed to the chemotherapy. So there are a few considerations like that when they get the very young tumors with chemo. But the radiation I saw with young people was all external beam, and the external beam radiation does not leave the person radioactive. It travels through them and it's gone.
Okay, thank you.
You're welcome. Good question. Anybody else?
Mr. Beamer, for the neuropathy, can they use gabapentin? Does that work at all? Because that's a medication we've talked about often in this course.
Yeah, if the neuropathies, I don't know if gabapentin's preventive though. I think it just treats the pain. And most of the time the neuropathies is more like a little numbness of the fingers. And I didn't get a lot of people who complained of it being very painful. I don't think it gets quite as deep and pervasive as it does with our diabetics who have it extensively. Yeah, but I'm sure if it did cause some pain, we could do the gabapentin.
My mom's neuropathy was like debilitating and she took gabapentin.
Oh, did she? Yeah. So she had a really, I think that it's not on Chemomin, but the Taxotere I've heard gives really debilitating neuropathies. I've had people say they're really bad. So, and yeah, it would make sense that gabapentin would be the right drug. Thank you for offering that. Anyone else?
Nope, doesn't seem like it. Well, great. Thank you so much, Mr. Beamer.
Thank you so much.
Oh, you're welcome.
Yeah, thank you.
You're
Eye
very,
opening.
very welcome.
Thank
You're
you.
welcome. Okay. Glad to come in. I mean, if you had other questions, it's kind of it's my first love is oncology nursing. I feel like it uses all of me as a nurse, right? It uses my interest in science because you have to understand cell biology, and it uses, you know, my spirituality because people facing life and death often want to talk about spiritual issues and concerns, and of course then it uses, you know, my nursing knowledge with all systems because everything can come up, and so I felt like I was able to use all my skill sets. And I did it.
Thank you.
Thank you.
Any other questions for related to the course or this week? Otherwise, just get a hold of myself or Ms. Clark, and we will see you at some point during the week.
Thank you.
Thank you.
Thank you.
Thank you, SB. Have a good day, everyone.
Thank you.